Good morning, dear colleagues. Now we'll start with coronary artery disease. I believe you are already ready to listen and to understand the problem we should discuss now. Okay, so it's the classical picture how looks the person who experiences the angina attack. So this man came out the good refreshment place after the good meals onto the cold weather and having the pressing, squeezing substernal pain with the typical irradiation to the left shoulder, to the left arm. And it is associated with the presence of very significant narrowing of the proximal part of the left circumflexor branch artery. Now you see what is the problem. It's the insufficient delivery of the oxygen to the myocardium depending on the narrowing coronary artery. And you see here in the normal condition we have to support the equilibrium between the oxygen supply and oxygen demand, and when this equilibrium is destroyed, we'll see the development of the severe chest pain. We name it like the angina attack, with some other disturbances, with the increased wall stress, heart rate, decreased contractility, and so on. What are the main features of the stable coronary artery disease? You see here is the abbreviation. So these are the pathogenesis basis. What is the problem? It's the presence of a stable anatomical atherosclerotic endofunctional alteration of epicardial artery and or microcirculation. And the natural history looks like the stable symptomatic or asymptomatic phases may be interrupted, may be concluded with acute coronary syndrome. And the mechanisms of the myocardial ischemia are the fixed or dynamic stenosis of epicardial coronary arteries. Then microvascular dysfunction with focal or diffuse epicardial coronary spasm. And these above mechanisms may overlap in the same patient and change over time. The clinical presentations look like any physical or psychological emotional stress induces angina attack due to the presence of epicardial stenosis, microvascular dysfunction, vasoconstriction at the site of dynamic stenosis, and sure, in many cases, the combination of all the above-mentioned features. The rest angina usually is caused by vasospasm, focal or diffuse. It may be epicardial, focal, epicardial, diffuse, microvascular, and the combination of all mentioned signs. And the asymptomatic angina, it goes because of lack of ischemia and or left ventricular dysfunction despite ischemia and or left ventricular dysfunction. And at last, sometimes we see the presence of ischemic cardiomyopathy. It looks like the decreased myocardial function depending on the usually in most of the cases on the silent myocardial ischemia, and as the outcome we see the large cardiac chambers with the low contractility. The next, these are the typical localization of the angina-associated pain. Here is the usual distribution of pain with myocardial ischemia, and here are the atypical localizations. So the doctor must take into account all the features, but typically you may establish the diagnosis while discovering the typical localization of the pain. What about the traditional clinical classification of the chest pain? Typical angina must meet all three of the following characteristics, like substernal chest discomfort or characteristic quality and duration. And this chest pain is provoked by exertion or emotional stress. And at last, the third sign, this pain should be relieved by rest and or nitrates within minutes. Not 5, not 10, but few minutes, 1-2 minutes. We can speak about the atypical angina, probable, when it meets two of these characteristics, and non-anginal chest pain here lacks or meet only one or none of these characteristics. Now, it's the worldwide accepted classification of angina severity proposed by the Canadian Cardiovascular Society. Class 1. Class 1, we can speak about it when the ordinary activity does not cause angina, such as walking and climbing stairs. And angina may evolve with strenuous or rapid or prolonged exertion at work or recreation. In the real clinical practice, we see this class 1 angina very, very rare. The next point, class 2. We can define it like slight limitation of ordinary activity, and angina on walking or climbing stairs, rapidly walking or stair climbing after meals, or in cold, wind or under emotional stress, and only during the first few hours after awakening, walking more than 2 blocks on the level and climbing more than 1 flight of ordinary straight at normal pace and in normal conditions. Class 3. We define it like marked limitation of ordinary physical activity when angina on walking 1 to 2 blocks. Remember, what is block? It is equivalent to 100-200 meters on the level or 1 flight of stairs in normal condition and at normal pace. And at last, class 4. It means the inability to carry on any physical activity without discomfort. Angina syndrome may be present at best. You see here that the myocardial ischemia with the chest pain is the tip of this iceberg. Chest pain, we can see chest pain, typical chest pain. We can take into account some disease history, but what we have to remember, the presence of ST segment and T wave changes, the systolic function, diastolic function, metabolic changes, decreased perfusion, and how can we evaluate these changes with ECG, with radioventriculography, echocardiography, PET scan. PET means positron emission tomography, and at last perfusion scintigraphy, PET scan, contrast echo, and so on. Now, it's the short preface for further discussion, because we have to evaluate any diagnostic method, any treatment method with the classes of recommendations and the next slide, the levels of evidence. Now, what means class 1 of recommendations? When the evidence and or general agreement that a given treatment or procedure is beneficial, useful, and effective. So, it is recommended and indicated. Class 2, what it does mean? When the conflicting evidence and or divergence of opinion about the usefulness, efficacy of the given treatment or procedure. So, class 1, 2, it should be considered because the weight of evidence opinion is in favor of usefulness, efficacy. And class B may be considered as well when the usefulness, efficacy is less well established by evidence opinion. And at last, class 3 of recommendations, it means this method, this treatment is not recommended. When the evidence of general agreement that the given treatment or procedure is not useful, effective, and in some cases may be harmful. And the levels of evidence. Level 1, when the data derived from multiple randomized clinical trials or meta-analysis. Level B, when the data derived from a single randomized clinical trial or large non-randomized studies. And at last, level of evidence C. It means the presence of consensus of opinion of the experts and or small studies, retrospective studies, registries. And sure, the best combinations of class of recommendations and the level of evidence is 1A. Now we'll see further about this approach. So, ECG, the plain resting ECG for initial diagnostic assessment. Sure, class 1, but the level of evidence C, because it's the opinion of the specialist consensus. When the resting ECG is recommended in all patients at presentation. And resting ECG is recommended in all patients during or immediately after an episode of chest pain suspected to indicate clinical instability of coronary artery disease. But sure, ECG is the routine examination method. We should perform it for everybody. And you see here how looks ECG stress test. Sure, we perform some modeling of the circumstances when the angina attack may appear. The left panel shows the normal ECG during the rest and after the exertion. If the patient really has the angina, you see the typical changes with the ST segment depression. So the diagnosis of the angina is now strictly confirmed. Ambulatory ECG monitoring. We name it also like Holter ECG monitoring. Holter is the founder of this method. He was the aerospace medical engineer. Okay, so ambulatory ECG monitoring is recommended in patients having coronary artery disease and suspected arrhythmia. Recommended strictly, but the level of evidence also looks not so good. But it's the opinion of the world medical community. And ambulatory ECG monitoring should be considered in patients with suspected vasospastic angina, sure, when the physical exertion does not induce the ischemia, but this situation is rather rare. The vasospastic angina we see in less than 5% of the patient having the angina clinic. And how the ambulatory monitoring, ECG monitoring can reveal the ischemia, you see here, is the baseline, and on exertion associated with sinus tachycardia, you see the depression of ST segment. And a few words about vasospastic angina, or the name of this angina is Prince Metal. It's the person who discovered, who explained this phenomenon. This angiospastic or variant angina is associated not really with the stenotic lesions of the coronary arteries, but due to temporary vasospasm. And during pain, by the way, it looks resembling an acute stage of MI, and in 1 hour, all the signs of so-called MI already disappeared. And now, at this point, we can establish the diagnosis of variant angina. Echocardiography. Is it useful? Sure. Resting transthoracic echocardiogram is recommended in all patients having a question when we need to exclude alternative causes of angina, to identify the regional wall motion abnormalities suggestive of coronary artery disease, to measure left ventricular ejection fraction for risk stratification purpose, and at last to evaluate the diastolic dysfunction. Look, level of evidence is B. And in some cases, we have to perform the ultrasound of the carotid arteries. It should be considered to be performed by adequately trained clinicians to detect increased intima-media ratio endoplaque in patients with suspected coronary artery disease without well-known atherosclerotic disease. IMT, look, intima-media thickness, and we can say ratio between intima and media thickness. And this picture, excuse me, unfortunately, the institution computer does not allow to uh, to show you the movie of the ECG is this echo pictures. It demonstrates the progressively decreased left ventricular contractility due to ischemia, induced by dobutamine injection. I apologize, it is not the problem of the original file. It depends on some failure of computer. So, chest X-ray. It is recommended in patients with atypical presentation or some suspicion of pulmonary disease. Sure, it is strictly indicated. And for any cases for suspected heart failure. But chest X-ray is the part of the routine examination. You must simply perform it in any case. The next point. It is so-called SPECT, single photon emission computed tomography. Very sophisticated, very expensive, by the way, method, but it allows us to get the information about the distribution of technetium systemib medication in the myocardium. It's the distribution of technetium systemib at rest, and on stress you see the lack of the distribution of it. It is associated with a rather significant ischemia of myocardium associated with the coronary artery stenosis, multiple stenosis, I'd like to say. And it's another approach, positron emission tomography. And you see here, it shows the hibernating myocardium in a patient with severe three-vessel coronary artery disease in the left panel, and the right panel after CABG. CABG is the abbreviation for coronary allograft bypass grafting. The patient experiences a dramatic improvement in the left ventricular function here. Very nice. Oh, I apologize. This computer does not allow to show any movie. What is the problem? I really don't know. What is the problem? I don't know. Severe coronary artery stenosis. The next one also, it does not go. It is not my own computer. The same occlusion of the right coronary artery. Well, blood test. The recommendations. The annual control of lipids, glucose metabolism, and creatinine is recommended in all the patients with known coronary artery disease. The next, you see here, our task is to confirm the diagnosis in the patient having some clinical suggestions about the coronary artery disease. And you see here, these are the sensitivity levels and specificity levels. So what means the sensitivity? It is the ability of the method to reveal some particular problem, like here, the myocardial ischemia. And what is the specificity? It means the ability of method not to find a problem when the problem really does not exist. And you see here the best combination of best levels of combination of sensitivity and specificity is for exercise stress echocardiography, but believe me, it has rather significant limitations depending on the I'd like to say ability of ultrasound to reach the good quality of picture and the operator skill. Sure, the sensitivity of all the methods is rather good. Specificity also varies, but if we take into account the prices, the expenses for any method, the most cheap is exercise ECG, and I'd like the exercise stress echo. All the other methods are rather expensive. And it's a very important slide. What does it mean in general? Some people say, some people think that the coronary artery disease in male and in female populations are the different diseases. Sure, it sounds like some kind of joke, but you see here that in young women, the typical angina is rather infrequent. And if you see some atypical presentations also in women, it is more rare. In atypical, in non-anginal pain, the probability of the real coronary artery disease in women is very, very rare. But if you consider this part of this slide, you see here the very significant predominance of male population in young and middle-aged group of the people, if we compare them with the women. So, I think you know such a joke, take care of men at first, because the male population is more and more prone to coronary artery disease than the female population. Why? Because the women are really protected with some hormonal features. So, what are the risk factors for ischemic heart disease? I think you know well then. What are the fixed factors, non-modifiable? Age, sure. Sex, what means sex? Male and female. So male are more prone for it. Family history, ethnic group, and already established vascular disease, for example, peripheral vascular disease. The next, major modifiable factors like smoking, the strict advice to give up to smoke, blood pressure control, sure, cholesterol control, we can do it, provide it. And sedentary lifestyle, physical activity is essential. It's essential how to modify the risk of coronary artery disease. Some other factors, control diabetes whenever it is present, obesity associated with sedentary lifestyle, not so clear homocysteine level, social class, psychological environment, type A personality, exogenous estrogens, important for women, alcohol, and other medical condition and infection. It's the very useful slide, I'd like to say. It's the general guideline for management of stable angina. It consists of 5 letters, A, B, C, D, E. What means letter A? Aspirin and anti-anginals. So antiaggregants and anti-anginals. B, obligatory usage of beta blocker and blood pressure control. C, control of cholesterol level and smoking. D, follow the appropriate diet and to control diabetes mellitus. And at last, education to explain the problem and exercises, physical exercises. So, and if you take and hold these rules in the account, you practically every time can provide the appropriate management of the coronary artery disease. Well, recommendations about diet. Saturated fatty acids to account for less than 10% of total energy intake through replacement by polyunsaturated fatty acid. I think it's obvious. Trans-unsaturated fatty acid also strictly to restrict the salt consumption below the 5 grams per day. Usage of fiber per day from whole grain products, fruits, vegetables, rather expensive sugar, but the next 200 grams of fruit per day with 2-3 servings. 200 grams of vegetables per day. Fish at least twice a week, one being oily fish. Consumption of alcoholic beverages should be limited to 2 glasses per day. For men, 1 glass per day. Okay, but the best way is to strictly restrict the alcohol consumptions, because where you can find the guy who use 20 grams alcohol per day, I don't know. Our people like the high dosage of it. The next, blood pressure control. These are the thresholds for office blood pressure, for home blood pressure measurement, and ambulatory blood pressure monitoring for 24 hours, 130 and 80. And you see here the levels for daytime and nighttime. But at last, the upper border of normal in any case is 140 and for systolic and 90 for diastolic blood pressure. Pharmacological treatment. What we can propose here? General, pay attention please for class of recommendations and level of evidence. Optimal medical treatment indicates at least 1 drug for angina ischemia relief plus drug for event prevention. It is recommended to educate patients about the disease risk factor and treatment strategy. It is indicated to review the patient's response soon after starting therapy. Angina ischemia relief. So, short-acting nitrates are recommended, like nitroglycerin, some inhaled nitrates. You see good level of evidence. The first-line treatment is indicated with beta blockers and or calcium channel blockers to control heart rate and symptoms. Class of recommendation A1 and level of evidence A. The next, second line treatment. It is recommended to add long-acting nitrates or ivabradine or nicorandil or ranolazine, according to heart rate, blood pressure, and tolerance. Class of recommendations 2A, level of evidence B. The next, for second-line treatment, trimetazidine may be considered. By the way, it's very popular in our country, but the class of recommendation is 2B, with the level of evidence B. And according to comorbidities tolerance, it is indicated to use second-line therapies as first-line treatment in selected patients as well. The next, in asymptomatic patients with large areas of ischemia, beta blockage should be considered. And in patients with vasospastic angina, calcium channel blockage and nitrate should be considered and beta blockage avoided. By the way, you see here, it's a Prince Metal variant of angiospastic angina. Event prevention. Low-dose aspirin daily is recommended in all stable coronary artery disease patients. You see here the level, the class of recommendations and level of evidence. Clopidogrel. It is indicated as an alternative in case of aspirin intolerance. The next, statins are recommended in all coronary artery disease patients. You see here the classes of recommendations, the level of evidence. And it is recommended to use AC inhibitors or ARBs. ARBs mean angiotensin receptor blockers if presence of other conditions like heart failure, hypertension, or diabetes are present. Well, so you see here, medical is the general approach for medical management of the patients with stable coronary artery disease. To relieve angina attacks, first line, short-acting nitrates plus beta blockers or calcium channel blockers with to decrease heart rate and so to decrease the consumption of the oxygen. And consider calcium channel blockers, dihydropyridine, calcium channel blockers if low heart rate or intolerance or contraindications to beta blockers. And consider combinations of beta blockers and calcium channel blockers, dihydropyridine, in Canada classification of class more than 2. And second line, you may add or switch the first line for some cases with ivabradine, long-acting nitrates, nicorandil, ranolazine, trimetazidine, and consider coronary angiography with further percutaneous coronary intervention. We consider stenting or CABG, coronary allograft bypass grafting. It's the approach to angina relief. The next, to prevent angina appearance. So, lifestyle management, control of risk factor, and educate, explain the patient the problem. And the usage of aspirin, statins, and consider in some selected cases angiotensin converting enzyme inhibitors or angiotensin receptor blockers. You see here, the next decision, the next strategy is the usage of some kind of intervention. And this Switzerland knife shows the opportunities with the usage of surgery and the combination of any catheter intervention with usage of some balloons, stents, rotational devices, and so on. Coronary allograft bypass grafting. When we use left internal thoracic artery with pedicle, we use it to perform the bypass of the most responsible artery, like a left anterior descending branch of the left coronary artery. And for less significant, for less important regions, we use the saphenous vein graft. But usually during the CABG, we see the combination of the usage of left internal or mammalian thoracic artery and saphenous vein graft combination. The next one, I really don't know. I simply wanted to show you the movie, but on this computer it looks rather impossible. Why? I don't know. The next stent implantation procedure. I have to skip this movie. Excuse me, it is not my own problem. Maybe this should go. No. So I have to show you just frozen pictures. When you see here, it's the right coronary artery. Here is the very significant stenosis and the restoration of the lumen of it after percutaneous intervention. And here is the next result, also the right coronary artery with the severe stenotic lesion and with the restoration of it after angioplasty. Now you see the global strategy of intervention in stable coronary artery disease patient. So, if the patient has significant coronary artery disease plus ischemia with the involvement of more than 10% of myocardium and having the optimal medical treatment, and if the doctor considered that the revascularization is possible, this revascularization should be performed, taking into account anatomical factors like single multivessel disease, left main lesion, last patent vessel, chronic total occlusion, proximal LAD, syntax score, clinical factors, age, gender, diabetes, comorbidities, frailty, left ventricular dysfunction, tolerance of medications, clinical scores. The next, technical scores with incomplete, complete revascularization, post-CABG, post-PCI, extensive total calcification, and local factors. Volume, quality of center operator, patient preference, local cost, availability, waiting lists. And if the patient has the indication and no strict contraindication, we can consider the CABG, coronary allograft bypass grafting, PCI, percutaneous coronary intervention, and hybrid approach using CABG and PCI as well. And if revascularization failed, When revascularization is not possible and the patient has refractory angina, unfortunately, we sometimes meet this situation, we can consider some alternative approach. So to re-evaluate the drug therapy, to re-evaluate the pain syndrome management, counter pulsation, that's for some terminal condition. Some experimental method like spinal cord stimulation, and the very popular approach, the usage of stem cell therapy. We really don't know the efficacy of such approach, but in any case, we have to attempt to improve the coronary circulation in these patients. But the most frequent restrictive factor, what is? It is the low left ventricular function, bad left ventricular function. Why? Because if we consider the cabbage for these patients who have very bad contractility of the left ventricle, you must take into account that cabbage should be performed in pump-on modality. What means the pump-on? It's the cardiopulmonary bypass machine usage with the with induced asystole, with the stopped heart. And when we'll finish the surgical intervention, we have to start the contractions with cardioversion. But if the patient has the initial low contractility, the probability to restore the heart contractions is very, very low. So the surgeons simply refuse of surgery of these patients due to very, very high intraoperational risk for such patients. And at last, before to finish our lecture, I want to remind you these general rules for management of stable angina, like aspirin and anti-anginals A, B, beta blockers and blood pressure management, C, cholesterol control and to stop, to give up, to smoke, follow the appropriate diet, D, and to control the diabetes, and to educate the patient, and to provide the exercise program. Now, I want to say take care. I apologize once more if I was not able to show you the appropriate movies. It is not my problem. It is the problem of the institution computer. And to say goodbye. If you have some questions, you can ask me. Okay, goodbye once more and take care.